Okay, so when we talk about the addictive nature of nicotine, we have to talk about nicotine withdrawal. Um, and we know that the withdrawal is difficult and often so difficult that that people resort back to smoking just to get rid of the uncomfortable symptoms that they're having, which are the symptoms of withdrawal. Typically, these symptoms they can begin within a few hours after the last cigarette, and they include things like irritability, frustration, anger, sleep disturbances, cravings, attention, and cognitive deficits, appetite changes. Usually, there's an increased appetite, and smokers start eat or those who are trying to quit smoking eat more and they gain weight, and then they often are upset by the weight gain. And so that's in addition to the withdrawal symptoms, that's often a reason for people to resort back to smoking. Restlessness, anxiety, depression, you name it, none of them are easy to deal with. Most of the symptoms manifest within the first 1 to 2 days, and they peak within the first week and then usually subside by weeks 2 to 4. But 2 to 4 weeks can be a long time to feel lousy for somebody who's going through many or all of these symptoms. So understanding this, understanding the the discomfort that goes along with these symptoms, and helping people to be prepared for them and to deal with them or prevent them are critical to success with smoking cessation. We can't, I can't stress enough how important it is to be prepared for these symptoms and have the patient be prepared for them as well, because your greater success with cessation attempts will come from being prepared and ready to deal with these things, okay? And with that being said, we also have to consider and really keep in mind that smoking is a two-part problem. So we've talked a lot about the physiological side of smoking, what it's doing to the brain, what it's doing to the pathways and the neurotransmitters and the chemicals in the body and all of those physiologic behaviors. But we can't forget that it's also a behavioral problem too. So people are often addicted because of the physiological components, but also the behaviors that you associate with smoking, or that you kind of always had something to do with your hand because it was holding a cigarette while you talked, or smoking with meals, or smoking while going out, or for some people smoking with drinking is heavily associated. So we have to also be prepared to deal with that behavioral side as well, which can be equally challenging and requires a lot of preparation for the patient to be prepared to tackle these things head on. Okay, we know that when a smoker gets help from a clinician, the odds of quitting smoking improve. So you can see some statistics on here: 1.7 to 2.2 times more likely to quit for 5 or more months with help from one clinician. And we also know that the number of clinicians intervening helps make a difference too. So the smoking success, the chance of being successful, it goes up when there's one or more than one clinician assisting with the cessation. So it tells us just more definitively that yes, it is really important for us as nurses to reach out to every single smoker that we encounter and help them on that path to cessation. Okay, so we talk about, well, what can we do as nurses, right? And I think that nurses are, and I would ask yourself while you're listening, what do you do now in terms of assisting your patients to quit? I think you probably both say, well, I ask if they smoke, right? That's part of most admission paperwork, health histories. You ask if they smoke, you document it on the chart. And then what else do you do with it, right? Do you go steps further? Do you go beyond simply asking? And so what we're going to talk about is something called the 5 A's, which is a strategy for helping smokers quit. First you ask, and I think we've got that. That's easy enough. The next is advise, assess, assist, and arrange. Okay, and we'll talk briefly about these different components as we go through. So advise, after you ask somebody to smoke and they say, yes, I do, the advice component is advising them of the risk. So in a very clear, direct manner, you want to advise your patients on the harms, the dangers, the risks of smoking, and of course, in a non-judgmental way. You want to advise them that it would be in their best interest to quit smoking. And then you'll move into the assessment part of where you assess where they're at in their quitting journey, and that could vary from not even being on their radar to they're really ready to quit. They just need, they just need some help. They just have some questions, or maybe they had already quit. But that's where you need to gauge where they're at so you can best intervene. How do you help them? But part of helping somebody is knowing where they're at. Somebody who's not at all ready to quit, not even on their radar, well, it wouldn't really be appropriate to spend a whole lot of time talking about, nicotine replacement therapies because they're not there yet. So after you assess and figure out where they are is where we'll assist. And that's where we'll spend a lot of our time talking here today about assisting depending on where they are on that spectrum of readiness to quit. So the first stage of that, they're not ready to quit in the next month, okay? Not on their radar, not interested, and they'll tell you, and that's okay. And it doesn't mean you give up on them when they're not ready to quit in the next month. It just means you have to take a different strategy, right? You have to, you still have to convince them somehow that smoking is bad and they should consider it. And if nothing else, you've planted a seed that who knows what will grow from that seed you've planted. Stage 2, they're ready to quit in the next month. They're saying, yeah, I'm ready to do it. We would never advise somebody to decide to, if they're interested in smoking, you can't just quit the next day. You really need to prepare them for it and really kind of get them ready for what they're going to face so they'll have a greater chance of being successful. Stage 3 is somebody who has recently quit within the last 6 months, and a stage 4 would be a former tobacco user, and that would be somebody who quit more than 6 months ago. So if they're not ready to quit, if they're in stage 1, you advise them to quit. You can give them information. You can ask non-invasive questions. You could give them some reasons. You could raise awareness of health consequences. You could definitely make it personal. How could cessation help whatever they're dealing with right now? Individualize it for where they're at in their life and how could they benefit. But you don't want to persuade, you don't want to beg, you don't want to, be pushy or judgmental, and you don't want to start forming a treatment plan for somebody to quit when it's not even on their radar. Okay. Things you want to ask instead, or consider asking would be, do you ever plan to quit? Or, why, a lot of people will say, well, I'll quit sooner or later. And you could come back with well, what might be a benefit of quitting now? Why might it be good to quit sooner rather than later? Or what would have to change for you to decide to quit sooner? Very interesting questions to ask that often elicit very interesting responses. And if nothing else, they oftentimes cause the smoker to actually just think about some things that maybe they don't want to think about. So keep that in mind. I always ask every single smoker, after I ask them if they smoke and they say yes, my next question is always, when are you going to quit? And it's, usually they laugh or what have you, but it opens up this discussion. And I'll tell you, these questions are very helpful, like I said, for planting that seed inside the smoker's head.